Welcome to the inaugural edition of Pop Health Hub, where we discuss all things population health management. I'm excited to have with me in the studio today Dr. David Nash, the rock star of population health management, who's also the founding Dean Emeritus for Jefferson University's Population Health Management Program. Thanks again for joining us today. And you also have a book that's coming out in the fall as well. Welcome to the studio.
Oh, great to be here. Yeah, rock and roll. That's awesome. My grown children will be very proud.
Yes,
yeah.
Yes. So tell us a little bit about the book that's coming out when, in the fall?
Yes, well, thanks again. So I spent part of the last 2.5 years with my co-author, Charles Wolforth, a science writer in Princeton, and we worked together to create How COVID Crashed the System, a guide to fixing American healthcare. And here's the punchline. The healthcare system was an airplane that crashed. We're the NTSB investigators. We find the black box and whoa, no surprise, we could see all the failures that led to the crash. That's half the book. And the second half is, okay, how do we fix this mess and get this airplane back in the air? So How COVID Crashed the System, coming out this fall. It's going to be great.
Well, we're looking forward to that.
Well, thank you.
Again, excited to have you here. And talking about crashing the system, the healthcare system has been kind of broken for a little while, hasn't it?
You would say so,
yeah.
Right? Of course.
Yeah, and you know, I just want to jump right into it, because employers these days are really looking for innovative ways to bend the cost curve for their healthcare for their employees. Telehealth, telebehavioral health, direct contracting, centers of excellence. There's a lot of things that are sort of being embedded in employer-sponsored plans. Where do you see all that going? What's sort of your crystal ball of where we might be heading with all this?
Well, first, why don't we give them a grade on how they've done in the past? And as a former dean, I'm an easy grader, but I'd give most employers like a B to B minus in terms of bending the cost curve. Here we are. We're 19% of the GDP with no end in sight. If we keep spending the way we're doing with nothing changing, by 2027, we're going to bankrupt the Medicare Trust Fund. So 50 cents of every dollar spent on healthcare in this great country comes from employers. They have not really done a great job bending any kind of healthcare cost curve. So let's get that out there.
Yes,
despite all the great tools that you described and despite the work of creating centers of excellence and getting the data, look, I think employers need a new model, and they have to be much more part of the conversation. They got to be at the table. Recent work talking about creating chief medical officers on the employer side, to talk to chief medical officers on the provider side. I think that's a step in the right direction. But the punchline here is this dialogue is not new, but it hasn't done a whole lot to bend the cost curve. Now, where we're going, I think in a endemic, post-pandemic world, I think we're in an entirely new world in terms of where employers are going as it relates to buying healthcare. Why do I say that? Well, if you want productive employees, you're going to have a new model. And I think about my millennial children, all of them in the workforce. They're never going to buy healthcare like you and I did. They're never going to call a doctor, sit in a waiting room. I mean, I'm giggling even thinking about it. So employers need a new model, as you suggested. Digital health. Let's label it that. That's certainly one piece. Employers also need better data on performance. Lots of employers, especially even national ones, they're already doing this, and they see variation from state to state, from zip code to zip code. They want to understand, how could this variation exist? And they want partnerships with great organizations like LVHN and many others across the country. So I think, to answer your question, where are we going in the future? More partnerships, better data, and a recognition that they have to have a seat at the table.
That's interesting. So you mentioned the health systems. Where do you see the health systems fitting into this new paradigm, if you will, with employers? Is there going to be a more intimate relationship?
Well, I certainly hope so, especially as you see the merger and integration of large delivery systems, right? Let's take a step back and look nationally. So Common Spirit, Ascension, these are gigantic, multi-state, hundreds of hospitals. They'll be able to have a national conversation with General Motors and Ford and American Express and JP Morgan and everybody else. I think regionally, for places like Jefferson, like LVHN, I think we're going to see more of a direct kind of contracting, call it, with a provider organization, with the payer organization, and maybe the employer right in the middle. I could sort of visualize, 3 concentric circles, right? So you have the provider group, the payer organization, the employer, and right in the middle is all the data and the analytics you're going to need to make some good decisions. So I hope they're up for it. We have a long history of business coalitions in healthcare, both at the local level, like the Philadelphia Business Coalition, at the national level. So they've done a good job looking at things like improving safety, so kudos on that. They've done a good job on recognizing the social determinants of health, kudos on that. What they haven't been able to do, which no one's been able to do really, is bend that cost curve. Yeah. And maybe if they have a seat at the table and they have good data, that gets the conversation going.
It's interesting. So you mentioned payers and providers. What about situations where the provider is the payer?
Yes.
Essence, right? So I think you've coined that term, payvider.
Yes, it's a clunky term.
So talk a little bit about that.
Sure.
Because what I see is obviously the larger companies that you've mentioned, the Amazons, the Walmarts, the Home Depots of the world, they're already here in this space. But that middle market, those smaller organizations, haven't yet adopted this yet. I think they're a little bit skeptical about it. So what would you say in that regard?
The whole idea of the payvider, clunky term for sure. We've been talking about it for 4 years. We spend a whole chapter in how COVID crashed the system on what's a payvider. But I think that is a really important movement in the marketplace right now. Jefferson's a payvider for the first time ever, now that we own a Health Partners plan. Many other academic medical centers and large integrated delivery systems have some sort of relationship with a payer. And that's important because the payers, say what you want, the payers, they've got the skill set to bear risk, right, to understand the cornerstone of how insurance works, to have the actuarial firepower. One diagnostic question I like to ask of providers is, how many actuaries do you employ? And usually the answer is, what's an actuary?
Exactly.
Right. So I think the payvider, again, clunky term, comes in a couple of flavors. One is the providers owning a payer. That's one model. Right. The other model that we've talked about in the book and elsewhere is a joint venture where payers and providers say, well, let's create a third entity. And then there's all other models that are out right there, purchase and equity share. The models really are interesting, but what's more important is the culture. Here's what I mean. I've been a primary care doctor for 35 years, and I've studied doctor behavior for 3 decades. We know that when you change economic incentives for physicians of all types, sizes, and shapes, and ages, you change the clinical practice of medicine. Let's do that again. Mm-hmm. When you change economic incentives, you change the clinical practice. Right. That's what the payvider is all about. So if we have a deeper relationship with the payers and we understand what's in their toolkit and we bring the providers and payers together, well, I think we have an interesting opportunity to change the culture of practice, be more cost effective, follow practice guidelines, be more judicious in our use of resources, and maybe eventually improve outcomes. Oh, and by the way, reduce waste along the way. Yeah. So I'm hopeful that this payvider, rapidly evolving model might be one part of the answer. Now imagine that an employer now sits at a payvider table. Yeah. Well, that makes it pretty efficient for them. So those are the 3 concentric circles coming together.
Does it give the employer a little bit more negotiating power? Do they have a little bit bigger a seat at the table?
Well, I think it depends a lot. Well, healthcare is local in this great, big, complicated country. Depends on the employer, depends on the type of employees they have, depends on the regional relationships that they have with the provider, historically speaking. That's a tough question. I think at the national level, we are going to see I think expansion in the centers of excellence, definitely, and also, as our informed listeners know, Amazon and One Medical. Okay, bring it on. Yeah. We've been talking about this for 3 years, pre-pandemic, and maybe somebody said to me, maybe this is Haven 2.0. Okay, Haven 2.0. Call it whatever you like, right. But I think this is a shot across the bow for all employers. And let's not forget, Walmart is definitely in the healthcare business, right? And CVS is in the healthcare business with Aetna. Right. So we're going to see all kinds of what I would describe as very exciting, innovative models. I think every large employer in our great country is watching very carefully this new Amazon relationship.
Glad you brought up Amazon, because I just read something the other day that obviously that's a clear direction of a large employer going directly to the provider. Right. And they've tried to take that to the street, so to speak, in that they've tried to offer that to other employers and haven't gotten the kind of lift. I'm wondering where's the breakdown? And I think that's relevant here locally as well, right? Because there's going to be some barriers that we would have to overcome to pursue that model locally.
Yeah, so the breakdown, I think, is historical. And maybe, look, let's face it, mistrust, that's part of it, maybe misunderstanding of how health insurance really works. The average American, your head spins when you start talking about deductibles and co-payments. I have a headache thinking about it, right? Like most people. Right, sure. So buying direct, as Amazon appears to be doing, well, that's certainly one way. If you have, let's just say, 500 employees, and you have, 10 employees with very serious medical problems, well, I think the kind of conversation employers need to have is, what can we do together to help me, the employer, with my most seriously ill employees, with our goal together to get them back to work? Right? That's a very tough conversation. And employers with 500 folks, they just don't have the resources to do that. That's where they need, another party at the table to help with that.
What do you think some of the clinical advantages are in going direct in that case? So, we talk a lot about taking claims data along with clinical data, right, and bringing that together to create better outcomes. There's this whole transition away from a more fee-for-service model and more of a value-based approach towards looking at outcomes. How do you see that dynamic changing in this model?
Well, I'm a big believer, so let's get it out there. We've got to get on the road to value-based payment. And look, it has a lot of synonyms, value-based care, resulting in value-based payment. Maybe it's just, capitation in a different costume. I don't really care what we call it, but if we don't get on a road to, we're going to pay you to get a better result. Now let's discuss what results mean. We could talk about, patient-centeredness. We could talk about the clinical outcome. We could talk about the cost. I prefer saying reducing the waste. We could talk about the safety, right? So I think the combination of clinical data and claims data, that's sort of, to me, that's the secret sauce. But it's the beginning of the conversation. We've been in silos for decades, right? Most payers have had the claims, most providers have had the clinical data. These two silos don't talk to each other. We've had episode treatment groups and a whole lot of other abbreviations, but we really haven't been able to get actionable information back to doctors in a non-punitive way, delivered by local experts, coupled with training on how to improve. So if you do all that, if you provide all that part of the recipe, then get out of the way, because doctors will stampede to do a better job. But having all the right ingredients, that's one thing. Learning how to make the souffle and make sure it rises, that's another thing. So the ingredients are key, but then You know, that non-punitive feedback, that conversation with the medical leadership, the sharing of the data, overcoming these hardened prejudices from, you know, decades of siloed information. I think we all understand that that way of doing business has got to stop. And having the right data at the right time with the right leadership, okay, now we could sit down and say, hey, you know, what's going on here? And I like to say, as a primary care internist, I didn't grow up with report cards about my performance, but my attending physician daughter has. Right. And that's the hope for the future.
Aren't providers more uniquely positioned to deliver on that?
Uniquely positioned now versus historically, or
now?
Now, yeah. I think so. Without getting too personal about the family, right. You know, my wife and I trained together. We're both internists. We never had report cards. No one ever also taught us, by the way, to ask, you know, do you have a refrigerator at home? Can you afford the medicine we're giving you? You know, it was all about what we've come to call the tyranny of the visit. We're great. You come and see us. We'll take great care of you. Right. And just ask us how great we are. We'll be happy to tell you. That model is over. My daughter's training was much more of, well, I'm now a part of a system. That's a big advance, right? I know that there's a bell curve distribution of doctor performance. Holy moly, right? So Atul Gawande and all of his amazing work, and many others, Bob Wachter, Peter Pronovost, all of the leaders over the last decade of the quality movement have shown us, well, we're not all created equal. So let's figure out a way to move the mean, right? That's what we're really talking about. And you can't move the mean without good data, physician leadership, everybody at the table talking about it. Otherwise, we're back to the silos and we're all going to lose. Because at the end of the day, I do fear a couple of things. Some employers might say, you know, I'm giving up on this. And I'm just going to say to my employees, here's your money, you go figure it out. And then that's going to be complicated for people, right? So all of that, you know, defined benefit talk, well, okay, it might work for a sophisticated workforce. You know, even when Dr. Esther Nash and I sit down at the proverbial kitchen table to look at the health benefits that we have the privilege of having, it makes my head spin. Yeah. And, you know, how does the average family do it? So I think we got a long way to go here.
You mentioned the lack of trust that may exist with employers and their reluctance to sort of have a closer relationship with their health systems. Absolutely. What do you see price transparency, or how do you see price transparency changing that dynamic?
Yeah, that's a controversial question for sure right now. And, you know, smart healthcare reporters out of Kaiser Health and others, Julie, Appleby, and everybody, I mean, price transparency is a pretty complicated thing because it's price, not exactly the resource costs, as we would say in economics. So here's the scenario. Hospitals have resisted all price transparency for a decade, right? I think that's politically not a great idea. You know, in politics, there's a great expression, hang a lantern on the problem. So instead of doing that, AHA and others with lots of smart people have said, you know, we're going to fight this because this is how we maintain market stability. I think that's a lot of hogwash. I've been about transparency and accountability for the last 3 decades. So employers today might be in a better position because of some price transparency. But let's not kid ourselves. Your price transparency and mine might be totally different in 2 markets 1 hour apart, right? And again, it's price, not the resource cost. And it doesn't take into account charity care and the fact of the social determinants which cripple a county like Philadelphia County, right? Where we have 4 major academic medical centers and we're ranked last in Pennsylvania for the health of our population. That's all about the social determinants. So I think employers, though, need to take a broader view. So a couple of things. They have to understand the healthcare data place. They have to understand variation in care and variation in outcome. They might need a chief medical officer, what we might have called the occupational health doctor in the past. You know, she's got a different job description today. So, and they have to appreciate what are their employees like. So, you know, there's been some apocryphal stories in the press, even in the last few weeks, of talking to employees like, how many folks here are on food stamps? And a third of the hands go up. These are people making minimum wage who can't afford to feed their families. So who's ultimately responsible for that? So, you know, we can't make healthcare the final common pathway for every socially determined problem, right? But big employers, if they want to have a productive workforce in an endemic era, which I hope we're heading towards, they better find some new and creative ways for engaging with employees to keep them happy. And Bob, we haven't talked about mental health and opioid abuse and the great resignation. I mean, I think employers, being an HR director today of a large employer, that's a tough job.
Yeah. Well, that's all the time that we have today. I want to thank Dr. Nash again for coming into the studio. It was wonderful to see you again.
Likewise.
Look for your book out in the fall. So thank you again for coming in and this wonderful conversation back and forth. And that's all for this episode of Pop Health Hub. Join us again for the next episode when we have Zach Jones in the studio, Senior Sales Executive for Populitics Health Management Solution, to talk about our own direct contracting model. Thanks again for joining.